It's interesting, we are in tour 18 and we are debating steroids in sepsis. And even before I graduated in medicine, some of our colleagues were already performing trials comparing steroids with placebo in sepsis. And so what is good or interesting to realize is that whatever your generation, you have lived trials investigating steroids versus placebo in sepsis. So it's interesting to look at some aspects, and if we look at meta-analysis or here meta-regressions on steroids and the risk of dying, it's quite interesting to realize that depending perhaps on the dose of the agent, when you use high doses here, it seems to be an increased risk of death with steroids. Perhaps with lower doses, there could be some effect, but it's quite obvious that some trials are still above, some trials are below, showing perhaps some beneficial effect, and of course some others are really neutral. So we need to understand why we can have these variable effects. So for the low dose steroids, it's mostly driven by this kind of data here, showing that it can have some anti-inflammatory effect, but it is really modulating this effect, because indeed it affected some of these cytokines, but not all. You can see here IL-10 is not affected, some other cytokines are not affected. So indeed it can have some impacts there. And also, interestingly, we have here the fact that hydrocortisone administration helps to restore the sensitivity to vasopressors. And so we begin this evening by discussing the new vasopressors. But we have to remember that when we discuss high doses of norepinephrine, vasopressin, whatever, well, using the hydrocortisone may perhaps be a way to improve the hemodynamic state without having a price to pay in increasing noradrenaline or other agents here. What is the real impact on the shock reversal? Well, obviously, giving hydrocortisone hasten shock reversal compared to placebo in these kind of trials. And it is interestingly associated, at least in that trial in 201, with an improvement in outcome and survival in these patients. And so that trial from Gilaliana really pushed in towards the use of hydrocortisone in shock patients at that time. They also observed that patients not responding to the ACTH term test in terms of increasing cortisol levels in these conditions, these patients benefited quite a lot from hydrocortisone, while the patient who had a normal response failed to increase their survival rate when they were given hydrocortisone. Nevertheless, at that time, there were already some doubts embedded in that trial. Because indeed, we were told that this was a positive trial. Because indeed, we were shown these data here is a total population that indeed a p-value of 0.003. Okay. But it is really interesting to realize that these were not Kaplan-Meier curves. These were Cox regression. So there was some correction for some factors behind it. And if we look at the crude data, meaning that the 28-day mortality, which was a primary outcome of that trial, it was not significant. It was a p-value of 0.09. So it was not significant, even though it was sold as a positive trial, and everybody, including myself, jumped onto the use of hydrocortisone in that in patients with septic shock at that time. Interestingly, there were some other trials just after. And the Corticus trial was coming later on and showed exactly the same effect on shock reversal that was indeed hastened by hydrocortisone in these conditions. What's also observed is that shock reversal was exactly the same in patients responding to ACTH or in patients not responding to ACTH. So it was a bit troublesome, nevertheless. We didn't care so much at that time. Because indeed, the most important aspect is that indeed, when you do meta-analysis, indeed, the shock reversal is really improved by administration of steroids, hydrocortisone in these conditions, compared to no cortisone in these patients. However, looking at the outcome, it was not so good because indeed, the survival rate was exactly the same. And it was exactly the same in responders and non-responders to ACTH. So in the guidelines, it was a little bit puzzling. And so indeed, it was suggesting not to use a high dose of steroids, and that indeed we should not use it unless perhaps we have very severe patients where indeed we may consider to use hydrocortisone in these conditions. There were some other trials coming later on, and here's a Vanish trial who looked at vasopressin, also looked at steroids. And what was observed is that hydrocortisone compared to placebo was associated in vasopressin group as well as in norepinephrine group with exactly the same mortality. So no effect here in these patients of hydrocortisone. And then there was this trial here looking at prevention of shock by using hydrocortisone. So in patients with sepsis without shock, they give hydrocortisone. And what's observed is that the proportion of patients developing shock or not was exactly the same in two groups. And regarding the outcome mortality, there was no difference there also. And so indeed, at the end, when we do meta-analysis, what we observe is that there is no major effect of hydrocortisone in these conditions. Nevertheless, the guidelines still suggest that we should not use hydrocortisone in patients who have hemodynamically stable. If these patients are not hemodynamically stable, then we may perhaps consider using hydrocortisone. And then, of course, we had the truth that was coming, Fiat Lux. Where it came? From Australia, of course. What they did, they randomized a lot of patients. They randomized 3,800 patients, more than any other trial, more than even all the trials together, the other trials. And what was observed, the data came from Australia, a negative trial. So indeed, no difference between hydrocortisone and placebo in these conditions. And was observed still that indeed the hydrocortisone hastened the shock reversal compared to placebo. And when they looked at other aspects, no difference in 90 days mortality, no difference in 28 days mortality. But interestingly, because indeed there was a more rapid reversal of shock, there was also a shorter time in the hospital, shorter time in the ICU, shorter time under mechanical ventilation, and no difference here in renal replacement therapy, but it was quite seldom in both groups. So yes, short-term outcomes, time-dependent outcomes, yes, these beneficial with hydrocortisone. But no strong impact on outcome, and this may perhaps due to the immunosuppressive effects or some other aspect on the glucose and others, toxicity of the agent, and so at the end, indeed, no difference in survival. So that's the end. Well, not really, because Zoro is coming. And again, who is it? Jalianan, the same guy who published the first positive trial, was publishing in the same New England Journal issue, another trial. The hydrocortisone plus hydrocortisone in adult with septic shock. And guess what? Jalianan trial, positive trial. So exactly the reverse of the Australian trial. In the same journal, we have here a positive, significantly positive, improvement in outcome with hydrocortisone and hydrocortisone compared to placebo. Okay, it's not 3,800 patients. It's only 1,200, but nevertheless, I mean, it's quite significant here. And interestingly, consistent with the other data, we have also more shortening of the shock reversal, less ventilator-free days, and less organ failure-free days compared to the other one. And so indeed, again, you can see it more easily here. It has a shock reversal, it has a liberation from mechanical ventilation, it has the improvement in SOFA score in these conditions. So at the end, where do we stand compared to our guidelines here? If you look at systematic review, we can rapidly do it. The Australian did it. And then we have indeed this kind of data with no significant, because indeed across the one, no difference in outcomes there. And of course, we can compute and aggregate 1,000 trials. When we have one positive, one negative, we will always end up with the same kind of results. The only thing what they showed is that indeed a short-term outcome, time-dependent outcomes, were indeed each time significant here, with a duration of shock, duration of mechanical ventilation, duration of ICU, duration of hospital, all significantly decreased with hydrocortisone. But the problem of this meta-analysis is that indeed you always aggregate trials without trying to identify why you have differences between these trials. So we can put 100 trials, 1,000 trials. When each time we repeat exactly the same type of design in each of the trials, we will have always the same aspects there. So we need to really look at who may benefit and who may not benefit from steroids. Are there differences between trials? Not only in terms of outcome, but in terms of design or patient inclusion. And then it begins to be quite interesting, because indeed, look at the adrenal trial and the approach, the ADAN trial. Inclusion, 2 or more SIRS criteria. Okay, we don't use it, but anyways, we don't be vasopressors or inotropic. The butamine is inclusion criteria. So you give for shock, treated with the butamine, not with vasopressor. Okay, but for more than 4 hours. Exclusion, okay. Steroid use, expected to die, okay. The approach, septic shock, infection in SOFA score, okay. Norepinephrine dosage above 0.25 for at least 6 hours. So longer duration of shock and more severe, because there are some data of norepinephrine dose here. Exclusion, almost the same aspects here. What they give, 200 milligram continuous IV for 7 days. 500, same cumulative dose for 7 days, so almost the same thing, but they added fludrocortisone, 50 micrograms there. So is it the fludrocortisone that is driving the results? Difficult to say. But in a previous trial, Gianni compared hydrocortisone and hydrocortisone plus fludrocortisone. And in terms of survival, there was no clear difference there. Maybe the numbers were not enough to disclose a slight trend, but at least there was no significant difference there. And so they concluded it was not mandatory to give fludrocortisone in addition to, even though they designed their next trial using fludrocortisone in addition to hydrocortisone. Try to understand, it's quite difficult. Here, what they also observed indeed is that for the other aspect, the vasopressor-free days and so on, no difference between fludrocortisone compared to hydrocortisone. Impact of disease severity. This is something which is really obvious when you put the two figures side by side. Look at the mortality in the placebo group in the adrenal, and you change the color, I agree, in the placebo group in the GLA here. You can see that mortality here is way below, mortality way higher, survival is way below, 40% survival in placebo group here. Here we have 65% survival in the placebo group, which should be exactly the same in both trials normally. So there are some differences there. And if we look at the vasopressor doses at baseline, 50% of patients here at less than 0.2 microgram per kilogram per minute. While here, remember that the mandatory dose was 0.25, so already higher than this one as a dose. And you can see that the average dose was 1.2 microgram per kilogram per minute. So it was 6 times higher here compared to there, the dose of vasopressors they use in these patients. And interestingly, in the adrenal group, they also look at the doses of here. You can see that at low dose, no effect. But at higher doses here, it was hydrocortisone better. Not significant, no p-value for interaction, but nevertheless, the same signal was already there in the adrenal trials that the most severe patients may perhaps benefit from it. And then, if you look, it's not a meta-analysis, it's just my own look at it. If you look at the mean value of the norepinephrine doses in the positive trials and in the negative trials here, you can see that indeed the 2 GLL trials were characterized by a mean value above 1 microgram per kilogram per minute in these 2 trials that were highly positive. However, in all the other trials, you can see that the mean value of a norepinephrine dose were really minimal or lower here in these conditions. Other factors seems not to be relevant beyond the fact that indeed severity may indeed drive this kind of aspect. But we have to admit that it may be not only, of course, severity itself that may drive this difference there. There can be also some other factors. And these, of course, were not studied or investigated there. One of these may be the way the person individual respond to inflammation or other factors there. And looking at gene expression here in children, using 100 genes nanochips here, there were some different patterns that were developed here. And you can see indeed this kind of subclass here compared to that subclass there. The most interesting aspect there in these children is that these patients did not respond to steroids and had that mortality, okay, which was slightly higher than the mortality of this one. But nevertheless, this one had a positive response in terms to steroids. So the response to steroids is not only, of course, driven by the doses of vasopressors or baseline mortality, whatever, it is also related to the individual response to the septic process. And this has also been shown to be the case in subgroup analysis of the VANISH trial. Unfortunately, this phenotypic or transcriptonic response was only reported in or investigated in 117 patients among the 400 patients of the trial. What was observed is that they have SRS1, which are patients which are quite immunosuppressed, and in these patients, steroids did not help these patients. In these patients who were immunocompetent, you can see that indeed steroids were helping these patients in these conditions. So perhaps there is something there, in addition again to the usual severity, that we need to take into account. And so the conclusions from the campaign that indeed we should have precision medicine coming, and that we should target therapies according to the individual response, determining high risk of the patient, and using perhaps this transcriptomic aspect is something we should need into account. I will rapidly end up by looking at the adverse events. It's also quite interesting to look at it in these trials. If we look at the adrenal trial, it's quite interesting because indeed you can see that the number of, among these 3,800 patients with septic shock, the number of patients with any adverse event was 21 and 6. Any adverse event. I would love to receive this drug because even placebo there, only 21, only 6 adverse events is nothing. So it seems to be somewhat underreported, and include, of course, hypoglycemia, which is only 3 and 6. Quite strange, isn't it? Yes. You then look at the Alan trial. Then any event, well, 53%. So half the population had adverse events there. And then you can see that indeed, of course, what they looked at, there was no major difference except for one thing. Hypoglycemia, which was indeed much more frequent with hydrocortisone compared to the other agents. So we need still to be quite cautious there. Looking at neurologic sequela, interestingly, it was going in a good direction, not in the wrong direction. So not an increased incidence of ICU-acquired weakness, even though sometimes it's thought to be favored by the use of steroids in some patients there. But maybe a question of dose and time of exposure, of course, also. So where do we stand in 2018? Well, if you look at the guidelines, it's quite interesting because the guidelines say that we should not use inpatient antiseptic without shock, and in patient with shock who is not responding to fluid and high-dose vasopressor therapy, we suggest to use it. And where do we stand? Well, still in line with the relatively evasive guidelines that indeed we should administer hydrocortisone solely in patient with septic shock, treated with high dose of vasopressors and failing to rapidly improve. And so with this, I thank you for your attention.
Daniel, after the release of Adrenal and Approach trial, I've heard from some intensivists here how actually the hydrocortisone is dead, so in septic patients. But don't you prefer a more rapid weaning of vasopressors than a more longer one?
Well, it depends. I mean, in a patient who do not receive high-dose vasopressors, I don't think it's really a good thing, because indeed, we still have some side effects, some adverse effects. And the fact that indeed we have no change in mortality is a witness that we have some adverse effects we do not measure. Is it immunomodulation leading to supra-infection later on? Is it the increase in glucose levels, also perhaps contributing to some other factors, including immunosuppression and so on? I don't know, but at least these two effects there seems to be a price to pay that in low severity patients is probably not the good way to go. In the most severe patients, yes, there is no doubt, because indeed these patients have high risk of death, and then by adding hydrocortisone, it seems that you can decrease the risk of death of these patients. So I personally use hydrocortisone only in patients who are treated with relatively high dose of vasopressors. Again, it's somewhere above 0.5, between 0.5 and 1. And of course, not improving, meaning that you are going with the doses like this, or at least stable for a couple of hours. But I don't wait 2 or 3 days before beginning. I mean, it's on the first days that indeed, if my patient is not going in good direction, I will give it to try indeed to limit the side effects or adverse effects of the high dose of vasopressors in these patients.
With or without thiamine and vitamin C?
This is a totally different question. So I think that there is some place for vitamin C. Thiamine is more complicated. I mean, data are not against it, but are not in favor of the systematic use of thiamine. For vitamin C, we have quite a lot of preclinical data suggesting some potential beneficial effects. It's one of the drugs that may perhaps improve the microcirculation and in sepsis, also in ischemia reperfusion. So there are a lot of data compelling going exactly the same direction. If you discuss the Merrick data, I have to admit that I'm much more doubtful about these, because it's a kind of very special before and after observational data without any they did not request the RB for this kind of thing, because it is just a unit that decided to change something, and that suddenly everybody will receive a drug that was not used before. There was, of course, no warning to the patients, no agreement of the patient. Patient has not to sign anything, because indeed he was treated with that. And at the end, the other aspect, beyond the ethical aspect of the trial, is the fact that they also had such a huge difference in mortality that is totally unexpected. So I don't think that vitamin C is able to really carry such a high benefit there. There is probably some benefit. I hope there could be some benefit that need to be proven. I know that there are at least 2 trials ongoing in US for this. We'll see. I mean, if these are going the same direction, we should have done it more rapidly. That we are expecting now these results. But I would love to see these results confirmed, but I'm afraid that the signal will not be as high, and then the question will be to interpret the difference between trials.
Thank you, Daniel. You have a great job here today, and surely clarify a lot of questions regarding this vasoadmina and so on. So, queria agradecer então vocês aí, a presença, e estão liberados. Obrigado.